Stefan. Good morning, everyone. Thank you, Vicky, as well, for the generous invitation here. My name is Souvik Mitra. I'm a neonatologist in Vancouver, British Columbia, in Canada. I'm here to talk about something that is very, very close to my heart, and that is use of evidence-based medicine in the truest sense of the term in the neonatal intensive care unit. Now, I have two objectives of my talk today. First, to encourage each and every one of you to ask yourself the question every time you make a clinical decision or write a clinical guideline or create a quality improvement project or create a quality improvement bundle, um, ask yourself the question, have I um, used the principles of practice of evidence-based medicine? And second, I would like to emphasize that the first objective cannot be achieved unless we put patients and families first. I have no conflicts of interest to disclose. Now, we are all gathered here in beautiful Lisbon to talk about the future of neonatal care. Now, you might be wondering that how does this topic of evidence-based medicine fit into this theme? Because when we think about future of neonatal care, what comes to our mind is artificial intelligence and machines driving our healthcare. But I'm here to talk about a different future, a future where we put the family's wishes, values, preferences right in the center of clinical decision making, where we try and make meaningful connections with the families in the NICU, a future where the NICU is more human again. Now, we in the neonatal world take a lot of pride in promoting ourselves as proponents of evidence of as proponents of family-centered care. But for some reason, this philosophy is only restricted to low-risk decision making, such as some feeding practices or some other uh, low-risk care practices in the NICU. But for some reason, when it comes to critical decision making in the NICU, this whole philosophy goes right out of the window. A doctor comes into the room and declares that we will give this drug to protect your baby's brain, or we will use this drug to protect the baby's lungs, or we routinely start antibiotics here because it is standard NICU policy based on evidence. And that has created this perception of evidence-based care where we feel that, yes, it is a group of physicians, clinicians who come together to solve a problem, identify the problem that kind of brings them to their primary and secondary drivers of change, that leads them to the change ideas, which are the actual healthcare interventions, and that are standardized as standard NICU policy. So at this point, I would like to stop here for a second and ask our audience here the question, what do you think is the main purpose of a NICU guideline or policy, whatever you call it? Is it to standardize care, to make a rational clinical decision, or any other purpose that you think is the primary purpose? So I see patient safety. Okay, so I see standardizing practice, expert consensus comes up quite frequently. So standardize. Okay. So this kind of seems to be a bit of a theme to provide constant care, which is again standardization. Not surprised, because it is through our training, it has been ingrained that the primary purpose of a NICU policy or a practice guideline is to standardize care and reduce practice variation. But I would ask this question that isn't that in direct contradiction to our philosophy of providing patient and family-centered care? And that is probably the reason why you and I have both at some point conveniently deviated from a guideline or a practice bundle for the benefit of the family or the patient and shrugged it off saying that, oh, it's just a guideline, like Captain Barbosa. Now, if you and I have both done it at some point, then maybe it's time to take a step back and think a little bit more closely about this phrase practice variation. What do we actually mean by practice, by trying to reduce practice variation? What I would argue is that what are we trying to do here is cut down on unwarranted clinical variation. Variation that stems from clear deviation from the evidence, one that is based on the provider's needs and preferences. But on the other hand, a guideline should promote some degree of warranted clinical variation that is tailored to the patient's needs and preferences and also tailored to the local context. Now, if we can all agree that the true purpose of a guideline or a policy should be to cut down on unwarranted variation and promote warranted variation, then doesn't that conform with the basic principles of practice of evidence-based medicine that has been defined by Dave Sackett as a combination of three main pillars? First, using the relevant scientific evidence, that is doing the right thing, things that are proven to work. Second, doing it right in the local context based on your local resources. And third, and most importantly, making sure that those interventions improve outcomes that actually matter to families. And unfortunately, this third pillar is often neglected in our NICU practice policies, guidelines, decisions, whatever you call it. And therefore, despite the fact that we promote a lot of our decisions and guidelines as evidence-based, if all the three pillars are not incorporated in that practice bundle or guideline, it is not conforming to the principles of evidence-based medicine. Now, you might argue that these principles were created more in adult medicine. Do they really apply to the NICU context? Now, for the next few minutes, I would use the common example of indomethacin prophylaxis in extremely preterm infants to try and explore whether these concepts apply to our field as well. Now, before we go into the evidence, just taking a step back and kind of acknowledging the fact that this drug has been one of the most researched drug in neonatal medicine. If we look at evidence from Cochrane Neonatal, almost 5,000 babies have been randomized to trials of PDA prophylaxis. That includes more than 3,000 babies in trials of indomethacin prophylaxis alone. And that have shown us that this drug is quite good at closing the duct, and that may have a direct effect on reducing the incidence of severe intraventricular hemorrhage. The PDA closing effect of indomethacin does not seem to really translate into an improvement in chronic lung disease, while there are obvious concerns about the effect of this drug on the neonatal gut and kidneys, especially from observational studies. But nevertheless, due to its potential beneficial effect on the brain, indomethacin has been adopted routinely in quality improvement bundles to prevent severe IVH in a number of centers across the world. If you look at this recent study from the University of Alabama in Birmingham in the United States, they have adopted routine use of single-dose prophylactic indomethacin in their IVH prevention bundle, in addition to a number of other potential best practices, and they've demonstrated quite a significant reduction in not only severe IVH, but the composite of severe IVH and death. If you look at a similar study published very kind of close together in pediatrics, this time from California, they also demonstrated pretty similar findings. They have introduced the routine use of prophylactic indomethacin for IVH prevention in their smallest babies, in addition to a number of other potentially best practices. And they've also demonstrated more than 10-fold reduction in severe IVH and also a stark reduction in death. But these are just some isolated success stories and do not really reflect the um, the trend of indomethacin use in the United States, which has demonstrated a clear downward trend over the years from 2008 onwards, due to a number of um, concerns that have been raised by physicians that include concerns around nephrotoxicity, decreased cerebral and intestinal blood flow, and also the fact that the largest trial on prophylactic indomethacin, the TIP trial, though demonstrated a reduction in severe IVH, that did not really translate into a benefit in terms of neurodevelopment. And therefore, people have generally moved away from its use. And in addition to that, in recent times, there has been the issue of competing prophylactic agents. So if we look at this widely advertised QI project from the United Kingdom to reduce morbidity and mortality in extremely preterm infants, it outlines a number of evidence-based interventions that includes prophylactic hydrocortisone. But despite all the evidence on prophylactic indomethacin, that does not find a place on this list. That leads us to this rather uncomfortable question: why is there variation in evidence-based practice if it is evidence-based? Now, there could be a number of reasons. Are we not up to date on recent evidence? In 2024, given the wonderful work these organizations are doing in keeping us up to date, I don't think that's a problem. The evidence does not apply to the local context. Yes, that is probably a valid point, as I recently came to know that indomethacin is not even available in many centers in the UK. Third is something that we don't really like talking about. Do we really understand the evidence that we are reading? Now, given the number of interventions that we see being either adopted or discarded solely based on p-value cutoffs without a real appreciation of the magnitude of benefit or harm in relation to what's clinically meaningful, I doubt whether we are really understanding the evidence that we are reading. Finally, if we assume for a second that, yes, we are up to date on the evidence, it applies to my local context, and I've managed to understand and interpret the evidence correctly. Even then, the interventions have differential impact on important outcomes. And what's important to you may not be important to me. And we never bother to ask families what's important to them. So at the end of the day, all that we package as evidence-based practice are essentially policies based on how we as clinicians value outcomes in our local context. And that is the part of the big problem here. But you might argue that, no, we do involve parents in our quality improvement groups. Well, I would argue, is that good enough? Let's go back to this example of prophylactic indomethacin or versus prophylactic hydrocortisone, two competing prophylactic agents, where we had the opportunity in a recent study to explore this in a bit more detail from a parental perspective. And I'll kind of walk you through what we found. So the goal of the bigger project was essentially to create a clinical practice guideline on the use of prophylactic cyclooxygenase inhibitor drugs in extremely preterm infants. And we wanted to do it using the methodology that has been outlined by the GRADE working group. So as a first step, we curated the evidence using a network meta-analysis on all the available prophylactic cyclooxygenase inhibitor drugs. And we published that on the Cochrane database a couple of years back. Then we presented that evidence to families of extremely preterm infants, and also to adults who were born extremely preterm, to explore their values and preferences on the use of these drugs, and also on competing agents such as prophylactic hydrocortisone. And finally, we convened a guideline panel that included not only physicians, but also experts in GRADE methods, pharmacists, and most importantly, families and adults born preterm, to move from this evidence to create guideline recommendations using the GRADE evidence to decision framework. So for those who are unaware of how this process works, it actually gives you a nice outline of moving from the evidence to creating guideline recommendations. That starts off with formulating the clinical question, and most importantly, selecting the outcomes on which we are creating the guidelines. And that's where we involve the parents right at the outset. So that's how we try and put patients and families first, right at the beginning of the decision-making process. Once we have identified the outcomes of importance, we then curate the evidence on these outcomes and rate the certainty of evidence using standard GRADE methods. And finally, we use the GRADE evidence to decision framework to kind of move from the certainty of evidence to strength and direction of recommendations. In addition to kind of going through this pathway, we place special emphasis on predefining what do we mean by a meaningful benefit or harm. Because as I had mentioned, that it is not sufficient just to say if an intervention works or does not work. We need to figure out how large is the benefit and how large is the harm. Because at the end of the day, what we need to ensure is that we are not doing any net harm to the patient. And what we want to achieve is a net benefit. So for that, we used a partially contextualized approach that has been used by the GRADE working group to predefine what we mean by a small effect, moderate effect, or a large effect for each outcome. For example, a small change in death could have a very different meaning to a family compared to a similar magnitude in change for another outcome, say GI bleed. If we just say that a drug increases death and reduces GI bleed, it does not really give us the true picture. So we need to get a little bit deeper and understand the magnitude of effect in relation to the outcomes of importance. Then, once we have defined the outcomes and the thresholds of clinical benefit or harm, then we assess the certainty of evidence using the standard GRADE methods, where we assign the certainty as high, moderate, low, or very low, which essentially means that we assign the trustworthiness or we assess the trustworthiness of the magnitude of benefit or harm that we had kind of figured out by curating the evidence. So for example, in our study for prophylactic indomethacin, we found that prophylactic indomethacin There was moderate certainty of evidence to suggest that indomethacin led to a moderate reduction in death and a small reduction in severe IVH. Small or moderate being defined based on our discussions with the families as we kind of predefined the thresholds of benefit or harm. On the other hand, we found that, at least from randomized trials, there was no signal for harm with prophylactic indomethacin on gut complications. So now with this evidence, we now presented this evidence to the families using a cross-sectional semi-structured mixed method study, where we conducted the study in two phases. First, a pilot phase, followed by a more definitive multinational values and preferences study, where we involved 40 participants. Most of them were parents of extremely preterm infants, in addition to 9 adults who were born extremely preterm, with a median gestation age of the participant or their child at birth being 26 weeks. That ensured that every participant has had a lived experience of extreme prematurity in the NICU. We asked the participants to rate these outcomes on a scale of 0 to 100, 0 being least important and 100 being the most important. Not surprising, we found that death was rated as the most important outcome, followed closely by severe IVH, while chronic lung disease, as defined as need for oxygen or respiratory support at 36 weeks, actually was rated quite low by the families, which is interesting because chronic lung disease still continues to be one of the most important outcomes, most important primary outcomes, rather, in contemporary clinical trials. And that clearly highlights this disconnect between what we think is important versus what families think is important. So once we had identified what's important to the families, we then presented the evidence on these outcomes using these simple infographics that we created using the Magic App software, which you can use free of cost to create your own infographics. We summarized the evidence on all these outcomes and asked the families a very simple question: that based on this evidence from randomized trials, would you have chosen this drug for your child? Now, contrary to popular practice across North America and also probably Europe, most of the families, at least in our study, said that they would absolutely choose prophylactic indomethacin for their child, given its effect on reduction on this very, very important outcome of severe IVH. And that was kind of an aha moment for us, because we did not expect these results coming out of this values and preferences study. So this will probably go in later. Yeah. So I'll probably come back to that. So now, to make matters a bit more complicated and maybe kind of mimic real life, we presented those families with an option, the option of prophylactic hydrocortisone. Now, we obtained the evidence from the recent individual patient data meta-analysis by Schaffer that demonstrated with moderate certainty of evidence that prophylactic hydrocortisone resulted in a moderate reduction in chronic lung disease and a fairly large improvement in survival without chronic lung disease. But as we all know, that we cannot give these two drugs together because of its significantly increased risk of GI perforation. So they had to choose one or the other. So when presented with that option of choosing one versus the other, 2/3 of the participants who had initially chosen prophylactic indomethacin now flipped their responses and opted for prophylactic hydrocortisone. because they valued the, the improvement in survival without chronic lung disease way more than the reduction in severe IVH. And that was the point we realized that it is impossible to create a guideline that standardizes routinely the use of either indomethacin or hydrocortisone in the NICU. So with this rather novel information from the families, we brought that back to our guideline panel to create the guideline recommendations using this evidence to decision framework. Now, this table here outlines the different criteria of the framework, which essentially forces you to not only think about the best available research evidence, but also helps you consider the family values and also the local context, such as the resources available in your own center, cost effectiveness, issues around equity, acceptability, and feasibility. And the panel members have to provide their judgment on each of these criteria as applicable to their clinical question to come to a final strength and direction of recommendation, which could range from anywhere between strong in favor to strong against, or weak in favor or weak against. So coming back to our example of prophylactic indomethacin, our panel acknowledged that yes, based on the evidence, there was a small but definite reduction in severe IVH and a probable reduction in death. There was some evidence that there could be a slight increase in risk of chronic lung disease, while there didn't seem to be any effect on GI complications or long-term neurodevelopment outcomes such as cerebral palsy. So the scale, at least for our panel, tilted slightly in favor of prophylactic indomethacin. Now, the scale could have tilted strongly in favor of prophylactic indomethacin given the strong parental preference for its use. But given the fact that 2/3 of the participants flipped their responses to hydrocortisone when that was made available, tilted the scale back in balance again. So at the end, the panel provided a weak recommendation in favor of using prophylactic indomethacin only in extremely preterm infants at high risk of severe IVH at your own centers, with due emphasis on shared decision making when possible with the families before using the drug. Therefore, after all that extensive and elaborate exercise, the most evidence-based recommendation on prophylactic indomethacin essentially was talk to families before you decide. Now, where does that leave my colleague who's trying hard to create this quality improvement bundle on reduction in severe IVH on the use of prophylactic indomethacin? And this is like a real life problem. So just to give you an example from our own unit in Vancouver, I pulled the data from the Canadian Neonatal Network and compared that to our own center over the last 5 years. On the left, we have the rates of death or severe IVH in less than 26 weekers. The blue bars are our own center compared against the national average and the orange bars, while on the right, we have death or severe BPD in the same population. So as you can see on the left, that in the last couple of years, our rates of death or severe IVH have trended up above the national average. While on the right, over the last few years, our death or severe BPD has kind of stayed stable, but the rates are still pretty high. Therefore, should we include prophylactic indomethacin in our QI bundle to reduce that high rate of severe IVH? Or shall we move to prophylactic hydrocortisone to reduce the risk of death or severe BPD? Because we cannot use the two together. And that really puts a big question mark against our traditional practice of developing standard QI bundles. But given that the most evidence-based recommendation suggests the use of shared decision making, Can we not, instead of routinely adopting or discarding this intervention from our QI bundle, can we not make shared decision making itself the change idea and track the opportunity to have a discussion with the families, our process measure? Something to think about as the future of quality improvement and evidence-based medicine. Now, this is just one example, and there could be several other examples where maybe not, like in your own unit, this is already in place, such as the use of postnatal corticosteroids for preventing BPD in preterm infants. I know we have a very exciting session coming up on this, and I'm eager to learn more about the different evidence that has come out. But I'll use a couple of examples just to drive home the point on how this philosophy might work when it comes to the use of postnatal corticosteroids. Now, in recent times, we have been fortunate enough to have had a number of very well done evidence synthesis on this topic. I'll just choose one by Professor Lex Doyle, who has just recently updated their Cochrane review on late postnatal corticosteroids beyond 7 days. And that showed that use of late dexamethasone beyond 7 days results in a statistically significant reduction in death or BPD at 36 weeks with moderate certainty of evidence. But as clinicians, we always worry about the effect of dexamethasone on the brain and neurodevelopment. So to look at the evidence on neurodevelopment, we again have this quite elegant meta-regression by Professor Doyle that was updated a few years back that nicely demonstrates that the risk of death or cerebral palsy is clearly increased when postnatal steroids are given with a low baseline BPD risk of 36% or less, while the risk of death or cerebral palsy is clearly decreased if you're giving steroids when the baby has a high baseline BPD risk of 68% or more. Now, with these two evidence bases at our disposal, now let's look at a case in our own unit. So say we have a 23-week male infant, now 2 weeks old, struggling on high-frequency oscillatory ventilation, 70% oxygen at the baseline, goes up to 100% with minimal handling. So obviously this baby has a very high risk of developing severe BPD or even dying. So we plugged in the numbers in the NICHD BPD calculator, acknowledging all the limitations of this calculator. And what it gives us is that there is about an 18% or 19% risk of death, and the overall risk of death or moderate to severe BPD is almost 75%. So again, acknowledging the limitations of the evidence that we have and kind of acknowledging that the evidence that I presented includes steroids of all doses. If we, for example, apply this evidence to this group of patients, there would possibly be an absolute risk reduction of death or BPD of around 19%, with a number needed to benefit of 5. So given this, would you consider using low-dose dexamethasone in your patient with this clinical picture? Okay. No, that's okay. So we'll just go back to that. Yeah. So you have 23 weeks male, 2 weeks old, bad lungs, struggling on the ventilator with a fairly high risk of moderate to severe BPD. Would you consider steroids? So the answer looks pretty unanimous. Almost everyone in this room would give steroids. So now let's go back to a slightly different scenario. Here the baby is here the baby is not that unfortunate. 23 weeks, male, 2 weeks old, on conventional ventilation, 40% oxygen, moderate mean airway pressure requirements. So when we plug this baby's numbers in the calculator, the risk of death comes out as 7%. The risk of moderate to severe BPD is around 27%, much lower than the previous case, but still a sizable risk. When I plug in the evidence, the relative risks from that Cochrane review to this to this risk of to this baseline risk of death or moderate to severe BPD, we get an absolute risk reduction, a possible absolute risk reduction of 7% with a number needed to benefit of 15. So in this scenario, would you consider low-dose dexamethasone? So here we are seeing a bit of a split. About half is not sure. That includes me as well. A third would not give, and only a small fraction would consider giving steroids. So what are we seeing here? We've just looked at the exact same evidence. We have the same baby, but slightly different clinical scenario, and our clinical decisions are vastly different. So this is one example where just applying the best available evidence is not good enough. And therefore, in scenarios like this, a guideline to standardize the initiation of steroids does not really align with the core principles of practice of evidence-based medicine. Here, to do it right, you have to dig a bit deeper to understand the nuances of the clinical context and also understand the family values and preferences and the trade-offs of benefit or harm that align with the family's values. And that is exactly what I've been trying to highlight through my talk. So with these two examples, I would like to pose this question to all the QI champions here, is that can we not imagine a future of quality improvement that aligns more with these principles of evidence-based medicine, where if the most evidence-based clinical recommendation recommends shared decision-making, why can't we use that as our process measure and thereby promote the warranted clinical variation that we've been talking about? While for some other interventions that have been clearly shown to have a beneficial effect, such as antenatal steroids, caffeine, surfactant, you can go ahead and standardize those interventions as standard NICU policy and track its implementation using standard QI methods, thereby reducing unwarranted clinical variation. Food for thought. So I would like to wrap up with with one of my favorite cartoons by Paul Glazo on this leaking evidence to practice pipeline, where essentially to improve outcomes, we need to start off by doing the right thing. We need to start by what actually works, that is the best available evidence. Then we need to do it right in the local context. We need to ensure that that evidence is applicable in my local context and we're able to act on it. And while we are doing it, we need to ensure that all these interventions are directed towards improvement of outcomes that actually matter to families. And only when we bring these three pillars together, we can improve the outcomes of our babies in the most evidence-based, family-centered way. Thank you.